Hello. I decided to record this lecture that I'll be given on September 2025 at the ESNR meeting in Istanbul. I have more slides than I could show in the 20-minute time that I was given. So I decided to practice and record the talk over here. And after that, I will decrease the number of slides. So I'll be talking about pediatric back pain, imaging of pediatric back pain. The incidence of pediatric back pain is given as around 1% at 12 years of age, based on this paper. And what happens is, as age increases, the incidence of back pain increases. As you approach like 50s, 60s, more than half of the people will have back pain. And the incidence varies quite a bit too. Based on this paper from 2002, the prevalence in children was given as uh, 30 to 50%, so quite a high number. This year, ACR published the appropriateness criteria for back pain in a child. And it's a helpful document. They provide scenarios where which imaging modality should be used, if at all, from the least severe to most severe. I think they have 7 scenarios in the paper. I highly recommend it. Uh, but if there is only transient back pain and there are no neurologic deficits, the physical examination is normal. If there is no history or minor history of trauma, the yield from imaging is low. So probably one should entertain these factors prior to starting the imaging examination. But they talk about some red flags in the paper. If there are red flags such as these: morning stiffness, gait abnormalities, night pain, neurologic deficit, radiating pain, fever, and also such as unintended weight loss, pain lasting for more than 4 weeks, tachycardia, lymphadenopathy, so some systemic things, or abnormal spinal curvature. Uh, these are red flags, and that would indicate imaging of the spine. So in this talk, we are going to think about differential diagnosis of pediatric back pain, and I divide it into mechanical causes, inflammatory infectious causes, and neoplastic causes, and we'll show examples from each category. So in the mechanical realm, we have these four. The pattern to scoliosis is a very wide subject. Probably it deserves its own session. And lumbar disc herniation will be discussed in another session in the same meeting. So I will talk about spondylolysis, spondylolisthesis, and Scheuermann disease. So spondylolysis is essentially synonymous with pars defect. So what is pars? Pars is the junction of the pedicle, lamina, and facet. Pars and isthmus are the same thing, so they're used interchangeably. Uh, and the pars defect in children is usually related to repeated trauma, the so-called microtrauma. So we see the pars defects in children usually in athletes or children who are practicing ballet. In those situations, they're commonly seen. And almost 90% of pars defects in children are at L5 level, less frequently at L4 and less frequently at L3. So we have the drawing from StatDX and corresponding imaging from one of our cases, a 3D deformation showing the defect at the neck of the Scotty dog. We'll talk about that on the plain film. So no, here's an intact neck, and here's the broken neck of the Scotty dog. So no pediatric back pain imaging lecture is complete without a plain film, even though we are doing these less and less these days for the workup of back pain. Let's look at the 17-year-old girl's oblique lumbar spine X-ray. The Scotty dog is here facing to the left of the patient. And if you look at L4, the intact Scotty dog and its neck are seen. And if we look at one level up, it's maybe hard to see on this projection, but The defect is indicated by the arrow, and both the head of the scarlet dog is separated from its torso, and we're seeing the defect. Of course, these defects and edema-related defects are much easier to see on MR and CT. So if you look at the MR of the same child, we see bilateral L3 pedicle edema, as seen on these stir images, and on axial stir, edema extending into the posterior vertebral bodies are seen bilaterally. So on this 14-year-old child, the pars defect is at L5 as usual. We're seeing edema about the pars defect, but also edema in the soft tissues and sometimes in the facet joint itself. In the past, it was difficult to see the pars defect on the axial images, but with high resolution T1 Vibe 3 millimeter, it's almost always possible to see the defect itself. As we go from top to bottom, we are going to see the oblique-oriented facet joints. And as we go a little lower, we're seeing the pars defects in the coronal plane, different than the facet joints. And sometimes we see the edema characterized by T1 prolongation in the bilateral lamina, as in this case. So we see the subsequent facet joints inferiorly, again, in the oblique plane. So if the plane is right, sometimes we can see the defects on sagittal T1 wave images, as in this case, and the edema involving the facet processes. CT, we do CT less and less, but sometimes we still do it. This is such an example of a 15-year-old girl. The pars defect of L5 is labeled by the arrow. And on the contralateral side, due to changed biomechanics, there is sclerosis of the contralateral facet process and lamina. And on the axials, we see the same thing, sclerosis on one side and the pars defect on the opposite side. So same child's MR shows the edema of the superior facet. And we can see the edema on T-stir and T1 and some edema of the paraspinal tissues. So this is an acute fracture. The spondylolisthesis occurs when there's bilateral pars defects in children, and it's graded from 1 to 5 based on the slippage, anterior slippage of the vertebral body with respect to the lower vertebral body. Less than 25% is grade 1, between 25 and 52, and so on. So at grade 5, there is more than 100% slippage of the vertebral body with respect to the inferior vertebral body. So the examples are hard to find in children. The severe ones, we have grade 1 spondylolisthesis case, less than 25% anterior slippage of L5 on S1. And when we look at the lamina, there's edema on one side and no edema, but we can see the fracture, the pars defect on the other side. So one side is chronic, one side is more acute. And on the axial images, again, edema is visible on the right side, no edema on the left side, and the pars defects are visualized on the T2 wave images. And due to the spondylolisthesis, there will be corresponding neural foraminal narrowing as compared with the L3-4 and L4-5 neural foramina. Grade 2 is more than 25%, as in this case, bilateral pars defects. And another example showing the foraminal narrowing, more foraminal narrowing compared with the upper levels, moderate, possibly foraminal narrowing. And we do have a CT of a grade 2 spondylolisthesis. Again, pars defect on one side, pars defect on the other side. Sometimes these pars fractures may be comminuted and be more than one fracture fragment. And grade 3 is more than 50% slippage, anterior slippage, as in this case, another example of a grade 3. These will obviously result in more severe neural foraminal narrowing. So let's move on to Scheuermann disease. Scheuermann disease is a chronic condition thought to be secondary to Schmoll's nodes, and there will be involvement of 3 or more vertebral bodies. And the anterior wedging needs to be more than 5%, and the overall kyphosis needs to be more than 40%. If the kyphosis is greater than 75%, surgery is generally indicated. So how do we measure the kyphosis? Uh, from the level the abnormality begins to the level the abnormality ends, from the superior end plate to the inferior end plate, lines are drawn, and the angle created by the intersection of these two lines is measured. If it's greater than 40%, it's Scheuermann disease. And for anterior wedging, the same is done on a single vertebral body. Lines are drawn tangent to the superior inferior end plates, and if the angle is greater than 5%, there's anterior wedging. So some examples, um, we have some kyphosis, but also there is increased hypointensity of the intervertebral disc corresponding to actually intervertebral disc calcification, which is not an infrequent feature of Scheuermann disease. Wedging of some vertebral bodies, more than at least 1, 2, 3 vertebral bodies are involved. And there's another focal kyphosis, Schmoll's nodes, not as severe, probably not definitely fulfilling the diagnostic criteria for Scheuermann disease, but probably it will if left untreated. Another one, 16-year-old child, multiple vertebral body involvement, Schmoll's nodes, and some kyphosis. This is probably the most convincing of the examples. We have a 16-year-old child with kyphosis, and there are multiple vertebral bodies that show anterior wedging and kyphosis, Scheuermann disease. So as far as inflammatory infectious causes are concerned, we'll touch upon chronic non-bacterial osteomyelitis. We used to call this chronic multifocal recurrent osteomyelitis. Now it's called chronic non-bacterial osteomyelitis. This child had pain both in his ankle, which resulted in imaging by whole body MRI. There was some back pain too, and this lesion at T12 was found, which demonstrated T1 and T2 prolongation, and also some enhancement following administration of intravenous contrast material, but the adjacent discs are intact. So this was not biopsied, of course, but thought to be related to the chronic non-bacterial osteomyelitis. Spondylolischitis is usually bacterial inflammation of the intervertebral disc and adjacent vertebral bodies. Discitis osteomyelitis is the synonym. We usually use the latter name for it. There can be epidural pus displacing the posterior longitudinal ligament posteriorly, and also there can be subperiosteal abscess, which may extend anteriorly. So let's look at some examples. This almost 2-year-old child has loss of the disc height, and adjacent vertebral bodies show T2 prolongation with corresponding T1 prolongation, and there's a suggestion of subperiosteal abscess anteriorly and an epidural abscess posteriorly. We see convincing enhancement of the adjacent vertebral bodies, and the epidural abscess and anterior subperiosteal abscess are also visualized. So another example, 15-month-old child showing some focal kyphosis, height loss of the intervertebral disc, as well as the vertebral bodies, edema. And there is corresponding enhancement of the intervertebral disc, but not pus, epidural, or perivertebral. But interestingly, in this child, there is lateral subluxation of the cranial vertebral body with respect to the inferior vertebral body. Another one, L5+1 disc is inflamed, and adjacent vertebral bodies show edema consistent with discitis osteomyelitis. And we do see the epidural pus and subperiosteal anterior pus on the FATSHIP T1 weighted images. So let's look at this example, 8-year-old child presented with back pain. L4 is certainly edematous compared with the adjacent vertebral bodies. The discs, however, appear intact. So the question is this some other inflammatory process, or is this due to infection? And inflammatory markers at the time of imaging were negative in this child. And we did a post-contrast fetch T1 sequence, which showed some enhancement of the involved vertebral body. So this child was followed up. A month later, there was declaration of disc osteomyelitis diagnosis, which showed a loss of disc height, and also signal is T2 hypointense compared with the adjacent intervertebral discs. There is abnormal heterogeneous enhancement of the vertebral body. And if we look at these stir images at time of presentations more closely, the one on the left is at midline, the one on the left is para-midline. So we said that the intervertebral disc is involved in this kind of osteomyelitis. So we should be very careful calling these normal. If you go to the side, actually, over here, we see some increased signal of the supine plate of the alpha vertebral body, and there is some decreased signal of the intervertebral disc, so which should have alerted us to think about this kind of osteomyelitis. So this focus is the clue. The intervertebral disc integrity is lost focally, which eventually became much more apparent a month later. So let's talk about the tumors. The tumors can be osseous or extramedullary, extradural. And then we'll talk about intradural, intramedullary lesions also. Let's start with osteoblastoma. Osteoblastoma is a benign tumor of the bone, which can involve the spine, as in this case, there is scoliosis, increased signal of the involved vertebral body on T2. And on the axial T2 images, there is extensive edema of the perispinal tissues. The clinical presentation is typical in these patients. Night pain, which responds to non-steroidal anti-inflammatories or aspirin, will be the typical presentation. And the nidus will be dark on T2, corresponding to this StatDX drawing. There will be sclerosis usually about the nidus or the involved posterior element. The same child's CT shows the sclerotic nidus surrounded by a region of hypodensity, sagittal, coronal, and axial images. There will usually be some sclerosis of the adjacent posterior arc or sometimes the vertebral body, as in this case. And these are responsive to either surgical resection or sometimes radiofrequency ablation. Osteoblastoma is very similar to osteoblastoma. They can involve the same tissue, same structures, namely the posterior elements are preferred. The distinction between them is the size. If the lesion is more than greater than 2 millimeters, 2 centimeters, I'm sorry, 2 centimeters in size, it is called osteoblastoma. The histopathology apparently is the same. Again, the same features, the sclerosis, about the lytic focus, and we see the scoliosis resulting because of the spasm. And on MR, again, similar to osteoblastoma, they entice inflammatory response in the adjacent tissues, as seen on these axial and sagittal stir images. Giant cell tumors are locally aggressive tumors, usually involving the sacrum or lower lumbar vertebrae. In this child, there's a large, almost symmetrical involvement of the sacrum, the anterior presacral component is marked with the arrow. There is sparing of the sacroiliac joints, but they may be involved in more extensive disease. The same child's MR shows heterogeneous signal on stir and intense heterogeneous enhancement of the lesion on the post-contrast images. We'll see another example. This is a little lower. Mid-sacrum is involved in the 17-year-old child. Again, heterogeneous on stir, relatively homogeneous and relatively intensely enhancing mass on the contrast enhanced images. There will be obviously involvement of the sacral canal and sacral foramina, depending on the extent of the disease. Aneurysm bone cysts can involve the posterior elements or the vertebral body, characterized by a lytic expansile lesion and cortical breaks on CT. The blood levels or fluid levels are easier to detect on MR. The same child's MR shows involvement of the lamina and pars. As we go to a higher magnification, one can make out the fluid or blood levels within these multiple compartments. Ewing sarcoma is not an uncommon tumor of the teenagehood. In this 13-year-old child, we see pretty much an extraosseous lesion involving the spinal canal. But when looked carefully, actually the vertebral body, the L4 vertebral body, is involved also, and there are these foraminal tumors that are narrowing the neural foramina. These tumors are small blue round cell tumors, and they will be biopsied, not resected. On the axial images, the large extraspinal component is seen involving the right psoas muscle, and enhancement will differ depending on the consistency. Here, the interspinal component is displacing the thecal sac to the left side of the spinal canal, and the enhancement of the extraosseous component is shown by the arrow. Another Ewing sarcoma case involving the S1 segment, the presacral component, the interspinal component, and heterogeneous enhancement of the S1 segment. Another one higher up involving L3. The vertebral body is involved heterogeneously, but the height loss is not there. And different than this kind of osteomyelitis, the intervertebral discs are generally normal in these tumors, allowing for us to discriminate those from infection. And the interspinal component is seen extending from neural foramen and displacing the thecal sac to the left side. Another one involving the sacral canal and L5 spinal canal, relatively intact size of S1, but the signal abnormalities are there and enhancing heterogeneously, and the tumor enhances homogeneously. LCH, lung canal histiocytosis, is related to abnormal proliferation of histiocytes. They can be unifocal or multifocal. And in the spine, the characteristic lesion is vertebral plana, as in this case. The vertebral body is almost collapsed completely. And the adjacent vertebral bodies are shown as such, and the collapsed vertebral body, vertebral plana deformity, very similar to what's drawn on StatDX. And the same child's MR shows intact intervertebral discs, but essentially non-existent vertebral body. There is a large interspinal and prespinal component, which shows quite intense enhancement following administration of intravenous contrast material. And on the axial images, there will be corresponding narrowing of the thecal sac. Another example resulting in focal kyphosis. Again, the intervertebral discs are intact, vertebral plana, and there's a smaller prespinal component, but no epidural component posteriorly. The involvement of the vertebral body may be asymmetrical, as in this case, one side may be involved greater than the other side. So if we look at the sagittal images, we can appreciate that, but also on the coronal images, the left side is more collapsed than the right side. And we can see the enhancing paraspinal components on both sides of the spine. And after treatment, the signal abnormality will usually go away, but the height will not be normal. The left side will always be shorter than the right side, as in this case. And if you look at more examples, in this case, the L5 height is reduced compared with the adjacent L4, and the signal is heterogeneous, and there's heterogeneous enhancement in an earlier case of LCH. LCH doesn't always involve the vertebral bodies. It can involve the posterior elements also, as in this case. The spinous processes are involved. There's a large posterior epidural component resulting in narrowing of the spinal canal focally. Another vertebral planar case, not all vertebral planar cases are due to LCH. So in this case, we have involvement of a lower thoracic vertebral body. And if you look at the post-contrast T1 weighted image, there is an enhancing tissue, perispinal, epidural, and prespinal. But I'm sure the careful eyes already noticed that the bone marrow is abnormal. It's quite bright on T1 and very dark on T2, so suggestive of very dark on stir, I'm sorry, suggestive of fatty infiltration of the bone marrow. So this child actually had rhabdomyosarcoma, pelvic rhabdomyosarcoma, which was resected. Of course, there are surgical clips, and the collapse was due to recurrence or metastasis of the, I should say, rhabdomyosarcoma. Another rhabdomyosarcoma case, metastatic rhabdomyosarcoma to the vertebral body, and also bodies, I should say, and also the sacral segments. And there is a posterior epidural component displacing the thecal sac to the left. This is one of those do not touch lesions. This child did have back pain, hence the imaging. Benign notochordal cell tumors are probably more common than we appreciate. In this case, there was involvement of the S1 segment, and there is increasing lung stir, decreasing lung T1, and no real enhancement. The key to make the diagnosis in this case is the really location of the lesions. They are very symmetrically situated in the vertebral column, as if somebody drew this lesion into the bone, and they are not expansile. They should be stable. They should not involve the neural frame in a benign notochordal cell tumors. And on CT, depending on the location, they are usually sclerotic, as in this case. Another example of a lower sacral benign notochordal cell tumor enhancing, I'm sorry, they are dark on T1 and they are bright on STIR. Of course, these tumors are not biopsied, so I don't have surgical confirmation, but these lesions remained stable over multiple follow-ups. And the interspinal tumors arising from the conus medullaris or spinal cord can result in back pain also. All these patients had back pain in their history, and there are different tumors arising from the conus medullaris. So not all tumors arising from conus medullaris are myxopapillary ependymoma, but this one was. But the next one was an endoplastic ependymoma, and next one was a ganglioma, and next one was a low-grade glioma. So typically, we call them myxopapillary ependymoma, but other etiologies can can result in a very similar appearance. And schwannomas, obviously, they don't arise from conus medullaris, but they may be difficult to distinguish if they are arising from cauda equina close to conus medullaris. So they enhance intensely, and they displace the conus medullaris and cauda equina to one side if they are high enough, like this one. This is a recent case. 13-year-old presenting symptom was back pain. There's extensive edema involving the spinal cord. And on pre-contrast and post-contrast images, we see edema and also a long segment enhancement within the mid-thoracic spinal cord. This child underwent a biopsy and diagnosed with a diffuse midline glioma, H3, K27 altered, unfortunately. So not all back pain is due to spinal causes. This child had Chiari-2. Intentionally, I did not talk about Chiari-1 and 2 because of time limitations. So this child did have Chiari-2 and had new back pain. So one, of course, thinks about retethering of the neural plug cord or sometimes development of a syrinx that may be the causes for new back pain in a Chiari-1 or 2 patient. In this case, we didn't find any change from previous exams. The only thing we saw different from before was enlargement in the uterus and also free fluid in the pelvis. So when questioned, it turned out this child underwent her first period. So this was a menarche case. So one can diagnose the cause of the back pain if one looks at carefully the spine MR images. So in this talk, I went over the differential diagnosis of pediatric back pain, mechanical, inflammatory, and infectious, and neoplastic causes were stressed. I'd like to thank for your attention. This will conclude this lecture. Thank you.